What we can do, what we have to do when we have to deal with a combination of an hemorrhagic shock and trauma brain injury. We saw that the early mortality in trauma is mainly due to uncontrolled hemorrhage, and also the mortality could be due to the fact that we have trauma brain injury. And once again, it's important to understand that all the strategy is damage control strategy, damage control surgery, damage control resuscitation. So the concept of the damage control is to provide only intervention which are necessary to control hemorrhage, and to focus on reestablishing survival physiologic status. So the first goal is to control hemorrhage, and when you set up all your trauma system, or you think about how I will organize in my unit the management of trauma, you have to think first to be able, with the surgeon, with the radiologist, to get a rapid control of hemorrhage. And another important point is to be very aggressive, to try to restore coagulation factor, and so it's another important point. And also, we reduce crystalloid administration to decrease dilution and to maintain coagulation factor at an adequate level to have the capability to coagulate. And also the concept of permissive hypotension to prevent any increase of bleeding by increasing too much your arterial pressure. So, what are the recommendations? The European guidelines recommendation, in terms of level of arterial pressure, the target is to have a systolic arterial pressure between 80 and 90, and it seems okay even if we tolerate a certain degree of tissue hyperfusion. But the goal is really, once again, to rapidly control hemorrhage. But when we have a trauma brain injury, so we know that we have to prevent any secondary brain injury. So we have to prevent hypotension, we have to prevent hypoxemia, anemia, hypocapnia, hypercapnia, hyponatremia, hyposmolarity, and to control the glycemia and to control the fever. So, looking at this, first, at the level of arterial pressure, we have a problem. What is the good level of arterial pressure? So, a systolic arterial pressure between 80 and 90, it could be not sufficient to have an adequate cerebral perfusion. So how to deal with this? The guidelines, the NICE guideline in UK give this advice for patients who had hemorrhagic shock and a traumatic brain injury. If hemorrhagic shock is the dominant condition, continue restrictive volume resuscitation. If traumatic brain injury is a dominant condition, use a less restrictive volume resuscitation approach to maintain cerebral perfusion. So it's not always easy to deal with this. It's really reasonable, but sometimes it's difficult to know what is the main problem when you have to take in charge patient. What about the European guidelines? The European guidelines recommend to increase the arterial pressure and to get a mean arterial pressure greater than 80 millimeters of mercury. That's great. I think it's a good recommendation. But when you have to deal with a very severe hemorrhagic shock, you know how it's difficult to get this level of arterial pressure. And you can only get this level of arterial pressure with vasopressor, because it's impossible to get it only by given fluid. Because if you try to do this, you will dilute a lot your coagulation factor, and you will decrease your capability to coagulate. So you can only increase with norepinephrine, and it's what we try. But sometimes when you have a huge hemorrhagic shock, it's not possible. So how to be smarter? So maybe a way, it's what we use in my unit, is to use transcranial Doppler. And by this way, you can have an idea of the velocity at the level of the middle cerebral artery. And main of the time, we deal with the pulsatility index because it's prevent you against the angle of insonation of the Doppler. It's a ratio, but what is interesting is to see the systolic and the diastolic velocity. And when the patient arrived, if it's good, if you have good velocity, you can leave the patient at the level of arterial pressure that he has. If you observe an alteration, if you have to face to, for example, an intracranial pressure, a high intracranial pressure, and you have a bad result when you perform your Doppler, you have to increase arterial pressure. But you know, it's easy to target the level of arterial pressure depending on what you observe with your Doppler. So I think it's a good way to deal with the level of arterial pressure. And the Doppler can always tell you, so there is an intracranial hypertension, and so it's very useful for the management of the patient. And it can show you also the impact of hypovolemia. If you have a huge hypovolemia, you saw that the velocity are largely depressed. So during the process, and when we have this combination of injury, the priority is to first to rapidly control hemorrhage through embolization or by surgery with a damage control strategy. The other thing that we have to do, we have to control the bleeding, and we have to control the surgeon also. It's very important. And maybe sometimes it's most difficult than to control the hemorrhage. Why we have to control the surgeon? Because don't forget, it's a damage control strategy. So the first thing is to stop the bleeding. And you have to do this very quickly to be able to take in charge the brain injury. And so don't spend too much time in the operating room, just stop the bleeding and say to the surgeon, that's okay, wonderful job, and now we are going to the ICU. And if there is no indication for neurosurgical procedure, we have to take this patient in the ICU and to try to stabilize the patient and to monitor the patient just to control the intracranial pressure. And we use more and more the brain tissue oxygenation monitor to control the oxygenation at the level of the brain. So just after you control the hemorrhage, the emergency is to stabilize your patient to be sure that you are able to control the intracranial pressure. So Another problem is the level of hemoglobin, because I think that we have to be concerned by this and to try to increase our target of hemoglobin to have a target around 10. So after the controlled bleeding, we have to think of this. Another very important point is that we have to prevent any hyposmolarity. So be careful with the ringer lactate. Use saline in this patient, because with the ringer lactate you can have induced hypoosmolarity and induce a deleterious effect at the level of the brain. So another important point is that we have especially to be concerned by the hemostasis in this patient to prevent any further degradation at the level of the brain, any increase of intracerebral hematoma or extradural hematoma. So it's in this patient, it's especially important to monitor the coagulation, and it is true that the strategy based on the thromboelastography is not completely validated, but what we ask here is that do I have a real problem at the level of my biologic hemostasis? So this kind of technique can say, oh, you are very late, you have to be more aggressive, so I think it's in day-by-day practice, it's very useful, and it's give you the possibility to very quickly control your biologic hemostasis, and it's especially important in this patient. So it could be, Jetil show us that it could be by given FFP or by a strategy drive by fibrinogen concentrate, and it's it's depending on what protocol is used is in your units. And another problem is that we have to control the PaO2 and the PCO2. The PCO2, we have to be very, very focused on the PCO2, because with PCO2 you can easily induce increase or decrease of the cerebral blood flow. So it's very important during the management of this patient, because this patient with the association of hemorrhagic shock and trauma brain injury, it's high-risk patient of developing acute lung injury or IRDS, and especially if they had lung contusion, aspiration on neurogenic pulmonary edema. And just this slide to show you how the fact that we do not control the CO2 could be deleterious. It's a study in a pre-hospital setting, but just to show you that if we neglect to be focused on CO2, we can increase the mortality. So we have, don't forget to control the CO2. And it's when we have to deal with a pulmonary problem in this patient, I think it's always tricky, and the level of PEEP, for example, it's possible to have PEEP even if you have a brain injury, but you have to control it, and to help you, you have once again the monitoring of brain injury, oxygenation, or the monitoring of intracranial pressure is essential. So to conclude, it's very important to have a clear idea of what are your priorities, what is the timing of potential neurosurgery, what is the timing of cerebral monitoring, after bleeding control, the timing of extra neurosurgical surgery, and it's very important to be very aggressive in your transfusion strategy and to have early and repeated monitoring of coagulation, and and be focused on the CO2 control and cerebral oxygenation. Thanks a lot.
Thank you very much, Jacques. Any question? A very short question, because we are running a bit late. That was short. Just one for me. We haven't discussed the hypertonic saline, which could be fine for the arterial pressure, good for the brain.
Yes.
What's your opinion about that?
Yes, no, I think it's interesting. I don't mention it because I think we need more studies to be sure, but I think it's interesting.
Yes. Jacques, thank you very much. It was a great presentation. I personally think that you can't get it right in those patients, so I think it's theoretical to discuss about blood pressure targets, and all you can do is, as David mentioned before, rationalize your interventions and just go. Get the time to a minimum. What is your impression about that?
Yes, I think that in pre-hospital setting, it's very difficult to know if what is the right arterial pressure. So I think that you have not to lose time and to get as quickly as possible to the hospital. And for me, the Doppler is very useful because it's sometimes you have a good Doppler with, for example, 90 millimeters of mercury. It's okay, and I have not to increase the norepinephrine. And sometimes you are surprised because you are at a higher level of arterial pressure. And when I remember well a young patient, when I performed the Doppler, it was terrible. So I thought that I was to face to an intracranial hypertension. It was not. It was only hypovolemia.
Thank you very much, Jacques.